çok teşekkür ederim Kerem Bey.
Estağfurullah.
İyi akşamlar. I'm very honored and pleased to have been invited to be with you at another TAP meeting after joining you in Antalya last year. My topic for today is optimizing clozapine treatment, continuing the theme of clozapine, which was begun this morning by others. This is my disclosure statement. I have no income or support from any of the pharmaceutical firms. I want to acknowledge my debt to my co-author for a pair of papers on the subject today. Dr. Sachin Phansalkar and I co-authored these papers from Psychopharm Review, January and February issues, which give much more detail than I have time for today, so I recommend that you obtain those. What I'm going to cover today includes the following. I'm going to go over the indications for clozapine. Dr. Meltzer covered that some this morning. I'll have a few more things to say about it. The pre-treatment workup and consent process for beginning clozapine, initiating and optimizing your dose, and then side effect management will be at least half of my talk, dealing with some of those difficult side effects which may prevent an adequate trial from being completed. So this is a how to do it lecture on clozapine. I'm going to make a number of points, starting with the fact that clozapine is underutilized, but in the interest of time, I won't repeat them here because I'm going to go into all of these. So why is clozapine still underutilized? Well, of course, there's realistic concerns about clozapine's adverse effects on the part of the physician and the patient. Also, some clinicians lack experience using clozapine, so they're uncomfortable with prescribing it, and they'll wait and do lots of other things before turning to clozapine because of their discomfort with it. And then there's the time factor. Some clinicians are just too busy with other work to prioritize the time and effort required to titrate the dosage and deal with the multiple side effects. So they will avoid it and choose routes of treatment that take less time. So these are some of the indications for clozapine. I'm going to discuss each for a few minutes. Treatment-resistant schizophrenia, of course, is number one. But as Dr. Meltzer indicated this morning, there are other indications. The US FDA has approved it for suicidal behavior in schizophrenia patients, even if they aren't treatment-resistant. And then it also has some evidence base for use in people with assaultive problems, substance abuse, polydipsia, and hyponatremia, and people who are generally non-adherent to their other antipsychotics. So let's start with treatment-resistant schizophrenia. Now, there are a number of algorithm projects out there that have brought together experts to try to determine the proper sequence of treatments one should go through before turning to clozapine. I'm going to mention three. They're all pretty much in agreement that you should move sooner rather than later to clozapine. This algorithm project, the International Psychopharmacology Algorithm Project, was developed in association with the CINP, chaired by Dr. Meltzer. This committee consisted of 18 content experts from 8 countries. And the World Health Organization has taken an interest in this algorithm. In fact, they have cited this on their website. They say that they are grateful to the CINP for this algorithm, which they recommend, followed by a link to the site. So what does that algorithm recommend? Well, basically, that you try 2 adequate monotherapy trials with non-clozapine antipsychotics. Adequate trials could involve a range of doses to explore the potential for response at different doses. A good paper to think about optimal dose is a paper by John Davis and Chen in 2004, which did an elaborate meta-analysis to try to determine the optimal dosing for each of the antipsychotics, typical and atypical. So you give an adequate trial of 2, and then you're ready for clozapine. That's basically what's found in this algorithm, although it does talk about earlier use for suicidal patients and other indications. Then there's the very well-known Texas Medication Algorithm Project. And here's their algorithm in its most recent version. For first episode schizophrenia, they recommend first any second-generation antipsychotic, and then, if that fails, another one, or it could be a first generation. In other words, any other antipsychotic, and then you're ready for clozapine. So they, too, believe that 2 trials, 2 monotherapy trials, and then clozapine. And after that, you can do add-ons and all these combinations that are not well evidenced. They have some exceptions, though, for suicidality, violence, comorbid substance. You could go right there after 1 trial. And also they have this piece here, which is consider clozapine after 1 trial if positive symptoms have persisted for 2 years, and they would require clozapine if they've had positive symptoms for more than 5 years and not responded, even though it is only 1 trial so far. And then there's an algorithm project at our own Department of Psychiatry, which is on the internet. We first published our first algorithmic version of this in 1989, so it's 20 years old now. And then our first internet-based version came out in 1996. And we've had flowcharts in the 3rd, 4th, and 5th editions of the ACNP model curriculum for psychopharmacology. Now, what makes this algorithm a little bit different is that we don't consider necessarily that all of the antipsychotics are the same in efficacy. That's a controversial concept. The other 2 algorithms say use your choice, any 2, and you're ready to move on to clozapine. We discern a little bit of possible difference based on a couple of studies. Actually, there's 3 now, but 2 studies that were not industry supported that seem to perceive a difference, at least in acute efficacy for first onset people or early onset people. And one was this McHugh study where they looked at 327 patients who were randomized open label to Haldol, aripiprazole, olanzapine, quetiapine, risperidone, or ziprasidone, all in pretty good doses. And response was defined as their dischargeability. How quickly could you get them to the point of discharge? Certainly a very relevant criterion for inpatient doctors who are under great pressure to get people out quickly. But there are many reasons to criticize such an outcome measure. There are various biases that could creep in. And here's their results, though. They were kind of interesting. 3 drugs, all clustered at about the same success rate in getting people out in 3 weeks. Olanzapine, haloperidol, the first generation, and risperidone produced about 90% ability to be discharged, whereas the other 3 were significantly less likely to be discharged at 3 weeks. Now, you might be inclined to have some skepticism about that, but many clinicians do find that they find it harder to get patients out quickly with these medications. That may have to do with dosing patterns in clinical practice, a variety of reasons, but it's an interesting finding. And this interesting study from Japan, Suzuki et al., randomized 78 patients who'd never been on any of the atypicals for an adequate trial. They were randomized to either olanzapine, risperidone, or quetiapine. If they didn't respond, they were randomized to one of the 2 that they hadn't gotten in the first trial. And then they were given the 3rd one if they still had not responded. And it's interesting that on the first treatment, quetiapine did significantly less well than the other 2, than the risperidone and the olanzapine. So once again, one atypical, one antipsychotic is doing less well than the other 2, and it's one of the ones that didn't do well in the McHugh study. So again, this provides a question of whether they're all the same in terms of their ability to get the patient well quickly. So our algorithm offers the following. You begin with any SGA, except we prefer not to use olanzapine as our first line because of its metabolic issues. Now, if you didn't do, depending on what you chose, if you chose either aripiprazole, quetiapine, or ziprasidone as your first SGA to try, and then you did another one of those for your second one, you've done two of the ones that may not be as strong as the olanzapine, risperidone, and the typical. So we would have a third trial before clozapine. But if you used risperidone first, then you can use anything else you want for your second trial. If you tried one of these first, we would recommend trying risperidone, olanzapine, or an FGA for your second trial. And then you're ready for clozapine. So mostly it's two trials, with the exception if you use these two. We don't feel that you're ready for clozapine if you've done aripiprazole and ziprasidone, for example. You should try one more. But you could debate that. Now let's move into a quick look at some of the other indications. Dr. Meltzer showed you the data on the INTERCEPT trial, which was a very large study, 980 patients being randomized to either olanzapine or clozapine. All had a history of suicide attempts or hospitalization to prevent an attempt within the last 3 years. And all had suicidal ideation with command hallucinations to do self-harm within a week. Only 27% were actually treatment resistant, and they were followed for 2 years. You already saw this slide of the results on the probability of a suicidal ideation or attempt favoring the clozapine over the olanzapine. Not a huge effect size, but given the large N, it was statistically significant and probably clinically meaningful, and the FDA approved clozapine for this indication. It's interesting to look at the adverse events because we had an opportunity to do a head-to-head comparison of olanzapine and clozapine, moderate doses of both. And it was interesting that in this study, olanzapine had more weight gain than clozapine. But in most other areas, clozapine had more side effects. Okay, so another possible indication would be assaultive behavior. Krakowski et al. Found clozapine better than olanzapine or haloperidol for a persistent aggressive behavior. And again, this was a group of non-treatment resistant inpatients. There's no FDA indication for this at this point, but the data is interesting. It did replicate some previous non-controlled data. How about substance abuse? Brunette found clozapine was effective for patients with schizophrenia and comorbid substance abuse. It may prevent relapse of substance abuse disorders. So clozapine is an important option to think about for patients with substance abuse. Polydipsia and hyponatremia. Spears et al. Reported clozapine produces significant improvement in patients with schizophrenia who drink water excessively and develop hyponatremia. Non-controlled work, but interesting. And then there's the problem of non-adherence. Now, adherence is often poor in patients with treatment-resistant schizophrenia. But adherence rates appear to be better with clozapine. It's not controlled data, but it's quite interesting. Now, many clinicians tend to assume that if a patient is non-adherent to their previous treatment, they'll be unlikely to comply with clozapine. Clozapine, after all, is an oral medication. There's no way of giving it IM and forcing it. So if they're not complying with the other orals, why would they take clozapine? Why would they participate in the required blood work? So they don't think of trying clozapine. But the fact is that once stabilized on clozapine, patients are actually quite adherent, sometimes remarkably adherent. And there was an interesting review that found that when we turned to allowing clozapine monitoring, blood monitoring, to be every 2 weeks rather than 1 week, a study showed that when you reduce the blood draws to every 2 weeks, adherence actually decreased. So those weekly blood draws and weekly visits appear to be part of the formula that keeps patients adherent and improved. So certainly we shouldn't avoid clozapine for the non-adherent patient. Okay, so those are the indications. Let's talk a little about the workup to start clozapine. I think probably most of you are familiar with the tests that need to be done to initiate clozapine. Certainly liver function tests, EKG at baseline, urinalysis, physical examination within the last 3 months, vital signs. If they have a history of seizures, clozapine is not contraindicated, but it should be used with caution. I'll have more to say about seizures in a moment. Weight, body mass index, waist circumference are recommended baseline tests for patients going on clozapine. And the baseline CBC, of course, must be greater than 3,500 cells per milliliter. And the absolute neutrophil count, or ANC, must be greater than 2,000. You should avoid combining clozapine with other drugs that can cause granulocytopenia, like carbamazepine. And avoid combining with benzodiazepines if possible. There's some evidence that that combination may increase the risk of respiratory depression, and there even have been some fatal reports of that combination, so there are warnings. I know a lot of patients are on benzos when they are about to get clozapine, and I'm not saying it's contraindicated, but they should be followed with caution. Now, how about informed consent? How do we get consent to this arduous treatment? Well, this is really the art of medicine, encapsulated here. I don't think the art of medicine is the art of combining 9 or 10 medications in some idiosyncratic cocktail that we are constantly reinventing in psychiatry that somehow produces the brilliant outcome. I think it's the ability to talk patients into taking reasonable, effective, evidence-supported treatments like clozapine after a couple of adequate trials of other treatments. That's much more evidence-based and effective than most of the other things that people do. So we have to present an appropriately positive and convincing description of the potential benefits of this powerful medication and its ability to improve quality of life, something well shown by different evidence. We have to discuss the limitations of the alternate approaches. That's an important part of any informed consent discussion. What are the alternatives and their benefits or risks? And if the complexities of administering a trial seem unworkable for an outpatient, consider an elective inpatient or day hospital admission to get the clozapine started. Now, what about the incompetent patient? More problematic. So when should you go for guardianship, get substituted judgment, have another person making the decision as to whether this person should get clozapine or not? Well, if the patient's unable to give appropriate informed consent. Now, prominent negative symptoms may render a person incompetent to decide if clozapine would be good for them to take. They may have little interest in any potentially difficult endeavor. Even getting up and going for breakfast may require a lot of motivation. And when you present the clozapine details, patients may very likely say, oh no, I have no interest in that. So that's very likely to be an incompetent patient. They can't appreciate the benefits, how much difference it could make in their quality of life. Or they may incorrectly believe that they are doing just fine. I'm fine, doctor. But it's obvious to anyone who knows them that they are totally disabled by their disease. Any competent person would be immediately aware that this person needs help. And then they may have exaggerated or paranoid fears of side effects. So these are all people who for whom competence should be questioned, court review obtained, and guardians appointed. Now, once you have your guardian in place and the guardian consents appropriately to clozapine, how are we going to give clozapine to a patient who is unwilling to take it? Well, we have a variety of techniques. We shouldn't feel uncomfortable about using them. Of course, there's crushed tablets mixed with food or liquids. We find in the United States sometimes that sweet cakes of different kinds, especially with sweet insides. It's a good place to stick the crushed clozapine and then offer it at snack time to the patient. We do that, and it enables the patient to take it. Certain patients who aren't suspicious of such things, it would require someone not excessively paranoid about being poisoned by their snacks. And next is to observe for 15 minutes to be sure the patient does not cheek or vomit their medication. If they're heading straight for the bathroom after you they take their medication, then you have to send someone with them to observe them, prevent them from doing that if you possibly can. Confirm absorption when you're going through these processes using blood levels. This is another of the indications for blood levels that Dr. Meltzer mentioned this morning. When you have a questionably compliant patient and you need to monitor how you're doing in getting the clozapine into their plasma. Another thing you may need to do for the patient who absolutely refuses, can't be fooled into taking it with crushed meds and so on, is to just firmly state to the patient that they have to take it. The court has demanded it, they have no choice, and you then hand it to them. Most of the time, we find that people will take it when presented that way. Sometimes you may have to use the IM backup method. You have another antipsychotic that you can give IM, like haloperidol plus lorazepam. Many of these patients hate IMs. So if they don't take the clozapine that's ordered, they're going to have the IM. So which is it? Well, many times they will agree to take the oral medication. Very, very rarely do we have to resort to this. But one shouldn't hesitate to do what you need to do after you have appropriate consent from competent guardian or court to do what you need to do to get the medication into the patient. Okay, let's talk a little about dosing. I don't know if you're aware, some people in the U.S. seem not to be aware that the package insert requires that the first dose be 12.5 milligrams because of, again, some rare reports of respiratory depression by starting at a dose higher than that. Just for the first dose, then you can give it twice on day one. For the elderly, you use half that. Extremely unlikely to be a problem if you use more than that, but it's good to know that that's in the package insert. Then you increase by 25 to 50 per day, get up to 300 to 400, maximum is 900. No single dose should exceed 450, according to the package insert. Again, this is because there's been no studies of single doses higher than that with respect to seizure and other risks. For outpatients, you probably should go at half that pace. If the response is unsatisfactory, check plasma levels. Best results, as Dr. Meltzer mentioned before, is looking at the levels of 350. One study showed that 450 is the threshold. Some others said 350. So something higher than that may be the optimal level. And the parent compound is what's most closely correlated right now with the clinical result. There's some suggestion that the metabolite may be important, but that evidence isn't all in at this point. If you have to interrupt it for more than 48 hours, you have to resume, according to the package insert again, at 12.5 milligrams for the first dose after 48 hours. But then you can quite rapidly, if they tolerate it, move them up to their previous dosage. Now, what if you are at plasma levels over 600? There's increased risk of toxicity, including seizures. If you're going to proceed with a plasma level greater than that, you probably should get an EEG first, as recommended by the manufacturer. And if seizure activity is seen, you probably should add valproate. If no seizure activity is seen, you probably don't need to do that. And certainly many patients will do well on lower levels than these. Use clinical judgment with this blood level data to find the best response that minimizes side effects. Clozapine is primarily metabolized to norclozapine by the P450-1A2 enzyme. There are some ultra-rapid metabolizers out there, as Dr. Meltzer mentioned, so you need to be on the lookout for them, and a blood level may reveal who they are. If they're not having a low level because of noncompliance, which is probably the biggest cause of low blood levels, if they really are surely taking it, then this is a rare possibility. And there are also phenotypes, phenocopies of this ultra-rapid metabolizing situation in cigarette smokers. Heavy cigarette smoke induces the metabolism of clozapine. Be particularly concerned if you have someone who was smoking and you adjusted their dose, and then they decide to stop smoking. They go on a smoking cessation program in your hospital. They now stop. Their blood levels may suddenly double or more, and you may get clozapine toxicity. Watch out for that, because the hydrocarbons in cigarette smoke are what induces the nicotine, the 1A2. It's not the nicotine, it's the hydrocarbons that are the inducer of the 1A2. Now there's also one very strong inhibitor of 1A2, which is fluvoxamine, Luvox. That, if you add that, that can increase blood levels 500% and produce severe toxicity. So be careful about adding Luvox to your patient with clozapine. But one interesting study found that to be a useful strategy to actually lower the required dosage of clozapine. They used 100 milligrams of clozapine combined with 50 of fluvoxamine. That put 2/3 of the patients above 350 nanograms per mil. Very interesting. The norclozapine levels were very low. Is that a good thing or not? It's unclear. Might be a bad thing according to what Dr. Meltzer said earlier today. But the patients in this study clinically did very well with this combination. And they also had a low incidence of weight gain and other side effects when getting this low dose. So it's an interesting strategy. It needs replication. I recommend you read this article about it. So here's a place to look up drug interactions if you're not familiar with all these, genemedrx.com. All right, we're ready to turn to managing the adverse effects of clozapine in a bit of detail. We'll start with agranulocytosis and neutropenia. I'm sure you're aware that there is a recent change in the monitoring algorithm. You now, at least in the United States, can decrease to every 2 weeks after 6 months, and you can go to every 4 weeks after 12 months. I'm not sure if those same guidelines hold in Turkey. I think in Europe they're a little more liberal than those guidelines. And they also provided more specificity about the ANC being particularly critical, the absolute neutrophil count, for when you should take various actions like getting repeat CBCs, daily CBCs, and when you have to stop clozapine totally, which is when the ANC goes below 1, you may not re-challenge with clozapine according to the package insert. I'm not going to dwell on that in more detail. It's in the package insert, but there may be some exceptions. There may be 2 exceptions to following those guidelines 100% that are worth thinking about to spare your patient the possibility of having to go off an effective clozapine trial. And those 2 are the phenomena of morning pseudoneutropenia and ethnic neutropenia. Neutrophils have a diurnal variation in their level. It's a circadian pattern with lower numbers in the morning, and it's driven by the cortisol cycle. Esposito et al. Hypothesized that clozapine may amplify this normal variation, with the result that the morning white counts may be much lower than the afternoon white counts. But clozapine white counts are typically drawn in the morning, just at the time when the ANCs may be at their lowest. So when neutropenia develops, it may be useful to repeat the test twice, in the morning and then at 2 p.m. for a few days, and see if there is a huge diurnal variation where it is normal in the afternoon. That is not neutropenia. If they have a perfectly normal ANC in the afternoon and it's only low in the morning, that's not a condition which we think progresses to agranulocytosis. So it is possible you could continue the clozapine and then routinely monitor the afternoon white counts, according to these 2 references with a variety of case examples. It's only at the case study level, this literature, but it's most interesting. Another phenomenon is ethnic neutropenia. The normal range for Caucasians is 3.6 to 9.5 for the WBC, But in African Americans, it's 2.8 to 9.5. It dips lower. So the range for African American patients is more likely to overlap with the range that could require discontinuation or failure to be able to even start clozapine. 25% of African American patients may be unable to start or continue clozapine because of this, and they may be deprived of the opportunity to have this effective treatment. Lithium is a potential treatment for benign neutropenias. It stimulates WBC formation, has a mild GNCS factor-like effect. It does not protect against true clozapine-induced agranulocytosis. So consider it in patients with that low baseline, such as African American patients. But if it drops below the mild neutropenia level, this isn't going to be a good solution. How much time do I have left? 5, okay. All right, I will briefly touch on a few other side effects, issues, seizures. It's a pretty straightforward one. They have to be managed, but it's not a contraindication. If they get myoclonic jerking during clozapine titration, short of an actual seizure, check plasma level, consider adjusting the dose downward, and perhaps adding valproate. And that's what you would do if they do have a seizure, reduce dose and add valproate. How about if they get myocarditis or cardiomyopathy? A very serious side effect with fatality rates that range from 1 in 67,000 in the US to only 1 in 1,300 in Australia. It's characterized by tachycardia, which is a common side effect, but if tachycardia is accompanied by fever, fatigue, dyspnea, chest pain, flu-like symptoms, and some signs like eosinophilia, enlarged heart on echo, it could well be cardiomyopathy. Heavy alcohol consumption is a risk factor. Stop clozapine immediately, medical hospitalization. Rechallenge has been reported, but recurrence can occur. So it's not forever necessarily ruled out, but you'd have to have tried everything else in the world, and then maybe with cardiology consult, try it again. This is the problem of weight gain. Dr. Meltzer already mentioned it, insulin resistance. It does probably not need much discussion by me, so I'll go quickly beyond it. Clozapine's at the top of the list there. And these are general approaches to treatment-resistant weight problems. How about constipation? This is a surprisingly severe problem. It affects 14% of patients. Here was a report of 102 cases of life-threatening constipation with a mortality rate of 27% from paralytic ileus and similar conditions. So avoid concomitant anticholinergics, excessive blood levels, use a high-fiber diet. Bulk laxatives are good unless they have obstructive symptoms. And then other more common but not so severe side effects include sedation. Caffeine may be helpful, but prescription stimulants may induce psychosis. Hypersalivation, there are a number of options. They can usually be tried, no great evidence base. Tachycardia, very common, usually doesn't indicate myocarditis. You may need to use propranolol or atenolol, especially if they go over 120. Obsessive compulsive symptoms affect about 10% of patients. You might consider sertraline as a possible remedy for it. Avoid citalopram or escitalopram, package insert warning against metabolic inhibition. Avoid fluvoxamine for the same reason. Avoid clomipramine, anticholinergic. Rebound psychosis, Dr. Meltzer mentioned how severe that is. It may be due to cholinergic hypersensitivity, so there have been reports of starting an anticholinergic like benztropine as soon as you abruptly have to stop the clozapine. That may enable you to head off the cholinergic rebound and the severe psychosis. There have been some reports of that being an effective strategy. So that's the end of my lecture. I have a little case vignette, but I won't have time to go through it. But basically, everything that could possibly go wrong did go wrong with this patient. He had seizures. He got the problem with, he got diabetes soon after we started it. Then his ANC dropped in the morning, but not in the afternoon. So we were able to continue with afternoon white counts, and he was able to be discharged. Thank you very much.